Hi everyone, I'm Lisa Butler from the University of Adelaide, and it's my pleasure today to be speaking to one of our guest speakers at the meeting, Professor Elena Castro from Spain. As part of the translational subcommittee, I was very excited to have Elena be visiting for the meeting, and it's just somebody that a lot of us have wanted to have you come and present for a while. So thank you so much for coming to attend the meeting and for interacting so fully with the program so far.
Thank you for inviting me. It's a pleasure to be here.
And welcome to Australia. What are your impressions so far?
Well, it's beautiful. It's the first time I'm in Australia. So once the meeting finishes, I'll spend some extra days and visit the country. It's beautiful.
Excellent. And what about your impressions through the meeting in terms of clinical care in Australia versus Spain? I mean, have there been some really obvious differences to you, or is it mostly fairly consistent?
Well, there's always some differences from some countries to others, depending on what is reimbursed, what are the resources for testing or to offer different treatment management to patients. But what I like very much from the meeting is the excellent interaction between clinicians and scientists and clinicians of different specialties. It's not very common to have this level of interaction. It's very nice.
No, that's true. And it's something that ANZUP has really evolved in that direction. So it used to be a much more clinical meeting, but I think, it's been great to be engaging people like myself and other basic scientists, as well as you mentioned other translational scientists from different areas. It makes the meeting much more rich. And as you saw today in the translational plenary, I mean, the room was still full of people really keen to hear about, the science and translation that's coming from these trials. So I think that's a really good sign for the meeting, that it really encompasses so much of that together. But let's talk about your science a little bit. So, you're probably best known for your work on the BRCA2 mutations and the germline studies that you've been doing relating that to prostate cancer. Do you want to tell us a little bit about your, career progression? Like, how did you become interested in this, or was it something that, was serendipitous when you did your research?
It was a project that in theory was going to be much shorter. It started when I did my fellowship with Professor Rosalie Niels at the Royal Marsden and the Institute of Cancer Research in London, that during the interview we were discussing different things, and I said, well, actually we don't know what is the role of inherited BRCA mutations in prostate cancer, because it is quite clear for breast, but not so much for prostate. She was working on prostate cancer at the time, starting all her projects, and this is how all it started. So the idea was just trying to define the prognostic implication of germline BRCA2 in prostate cancer, something very relatively easy. And then so we identify that often these patients are diagnosed with metastatic disease and aggressive tumors, and then we try to see what happened with patients with localized disease, whether the type of treatment they received had any influence in the outcomes. And what we observed was that either if they were treated with radiation therapy or with surgery, they did worse than patients without these germline mutations. Then I came back to Spain, or moved back to Spain, and continue with this line of work. And we, for many years, we've been collecting clinical data and samples from patients with metastatic prostate cancer at different stages, and we screen them for germline mutations in BRCA, but also in other DDR genes, and analyze the impact of these alterations on the response to the available treatments, confirming prior results, and also seeing that there were some differences between BRCA2 and inherited mutations in other DDR and HRR genes. And what we have done more recently was to expand this analysis not just to germline mutations, but also to tumor-acquired somatic alterations, and trying to see whether there could be any difference between germline and somatic, or BRCA and non-BRCA HRR genes. That is what I
which you presented. I mean, the effort that you must have gone to collect so many specimens. It must be one of the largest collections in the world.
Well, it is quite large, but perhaps what is more interesting is that when we collected that, PARP inhibitors were not available. So this didn't impact survivals,
yes, right.
So I guess we couldn't do that or get those samples anymore, because fortunately we now have PARP inhibitors, and this is something we can offer to our patients. But yes, this gave us the answer to how these patients do with conventional therapies. And we have also been investigating what it is that these tumors have that make them behave the way they do. And also some groups in Australia have been working on this. And it's nice because we have been completing the pieces of the puzzle.
Yep. And sort of complementing each other's work in that way,
yeah.
Which is nice. And, I'd just be interested in your thoughts, because, when we think about breast and prostate cancer, we often think that, they're often more similar than they are different. They're both hormonally driven and the like. And there's this reliance, obviously, in the familial setting on DNA repair genes. And so why do you think there's such a strong, favouring of BRCA2 for prostate as opposed to breast? So that's an area where they are obviously quite different. I know we don't have the answers yet, but have you got any thoughts about
No, but
I
think it has to be some tumor tissue-specific regulation, because in breast is BRCA1 alterations that are associated with some specific phenotypes, aggressive phenotypes, triple negative, whilst in prostate is BRCA2.
Yes,
so I guess it has to do with some tissue-specific regulations, but yet we don't know what those are.
Yeah, it's fascinating, really, isn't it? Yeah. I guess the other thing, when we're talking about familial disease, now there's a lot of interest, I guess, in BRCA2 families in screening the young men in those families for prostate cancer. So I assume in most places in the world, certainly here, that they can have earlier access to PSA testing, for example. Do you think some of those initiatives might change or hopefully mitigate some of the worse outcomes that you see with BRCA2 patients that in the past were discovered more serendipitously?
Yeah, the current recommendation is that these men start screening at the age of 40, 45, may depend a little bit on the guideline. And I believe that yes, for some patients for some carriers, that may result in better outcomes, because we may be able to detect tumors earlier before they develop metastasis. But on the other hand, it's true that even for patients with localized disease, treatment with conventional therapies is associated with poor clinical outcomes. So we need to detect the tumors earlier, we need the screening, but we also need to develop better adjuvant strategies or better treatment strategies.
Yeah. So that's the challenge, I guess, going forward. I guess to wrap up, I'd be interested to hear what you think in terms of, the challenges versus the benefits of being a clinician researcher. I mean, is it something that you would still recommend to, young clinicians coming through to have a research career as well?
Well, this is something you do when you are curious and you want to learn about the things you see in the clinic, the things you understand or you don't understand. And I think it's tough, and being a clinician scientist is not a very clear pathway, and in some systems it may be better, the pathway may be better designed, and the steps that need to be taken are clearly defined, but in other systems, in my system in Spain or in Europe in general, it's not so clear. So we end up doing medicine and at the same time the scientific career, trying to check all the boxes in both paths. Well, I think it is. I like it. I like it because it gives me the opportunity to understand the things that I may see in the clinic and to interact with colleagues with different skills and different knowledge. And to me, this is very enriching, and but it is true that sometimes it's tough. So for those who are curious, for sure, follow your heart. Yes. and don't abandon this clinician scientist path.
Oh, that's good to hear you say. And I guess mentors are very important in that too. Did you have any particular mentors that really supported you and helped you on that path?
Yes, Professor Ilse was an excellent mentor. So I spent 4 years with her, but still afterwards she continued to help me, and I think she set a very good example of how to combine these two things. And over the years, I have met fantastic people that have mentored me. Sometimes it was just a conversation that helped me decide on something. I believe we need mentors all the time. It's just that as we evolve, we may choose different mentors
for different, to sort of help us in different ways, and then we become mentors ourselves. Is that something that you are starting to do as well?
Yeah, well, and actually, I find it sometimes a bit difficult because I would like that all my mentees were successful in whatever they decide to do and be able to help them and avoid them frustration, like with my children, right?
Yes, yep.
But okay, that's not always possible.
No, that's true. Terrific. Oh, well, I think we might wrap it up there. So thank you so much for this conversation. It's sort of, cross the ground from career through to science, which is wonderful. And I think for any trainees that are out there, someone like Elena is great to talk to in terms of career paths and combining science with medicine at such a high level as you are. So thank you again, and we look forward to seeing more of your work in the future.
Thank you.